I was given the task to talk about prostate cancer screening. It is still controversial today when I'm going to talk to you. So, nothing to disclose for this particular talk. The only thing I have to disclose is I just came back from Montserrat last week. I was there for a week with Dr. Joe Daly. If you know the geography of the Caribbean, it's a tiny island south of Antigua. So half of the island here, there were people there, nobody lives there anymore. In 1980s, the whole island, 90% of the island was destroyed by Hurricane Hugo. And in 1990s, this was the capital, and the volcano erupted. 19 people died, everybody moved up north or moved to UK. It's a UK territory. So we worked in a tiny hospital up here, and this is the emergency department of the hospital. Dr. Daly is Montrealian, so he's been going there for 30 years. So first time I went in there, and the volcano. So this used to be out here, American University of Caribbean Medical School. So since the volcano erupted, they moved it to St. Kitts. And this was a whole beautiful town, and you could see the ashes and in the ocean. And behind here, this is an island, and it's uninhabited, and behind that is a Nevis Island, which is close to St. Kitts. You can see that in the shadow. It's a beautiful place. So as we talk about men are scared. And we actually went on to the public radio, and we went to the public forum, and the first question men asked, are you going to spoil my manhood if you do rectal examination? Men are worried. Men don't go to them. They've seen that when women go through their lifetime and how women, when they get to that age, and they're worried. They don't go to the doctor. So same reason here, we don't go to doctors. So I'll start with the case scenario. 50-year-old Caucasian, a healthy man, and wants to discuss PCA, prostate cancer screening with you. He has no family history of prostate cancer. He has minimally bothersome lower urinary tract symptoms. So how would you handle this gentleman? I believe this controversy still exists. 15 years ago, when we used to go to these meetings, the experts sitting on the podium, all 5, 10 people who are sitting on the podium will have different opinion. I think it still exists today. So if we have 50 people in the room, all of us probably will have different opinion how to handle this man in our office when he comes to you and talks to you about prostate cancer. So it still exists. In my talk today, I'm going to mention about levels of evidence, level 1 to level 5. Level 1 is the randomized controlled trial, the best trials you can have in level 5. Dr. Jain said this, and Dr. Greenberg said this, and Dr. Chawla said this. So those are the evidence which exists in the literature. Prostate cancer, as we all know that, is most commonly diagnosed solid cancer in men. And actually it's a third leading cause of death. As I mentioned second, it's a third leading cause of death after lung, colorectal, and then it's prostate. 1 in 7 men in Canada, the number is 1 in 6 in the US, will be diagnosed with prostate cancer in their lifetime. And 1 in 27 men will have a chance of dying due to prostate cancer. So autopsy studies have shown us that older we get, we are going to find indolent cancers in a lot of these men in their prostates as we age. So if you die of any other cause about 50 and over, you can have a chance for almost 50% or even 70 to 80%. What are the risk factors for prostate cancer? Age is the number 1 risk factor, so the chance to get a prostate cancer. Family history. If you have 1 close family member, your father, your brother, you have twice the risk of getting a prostate cancer. And black race. Not that they have a higher risk, but they also have a high risk of getting aggressive prostate cancer. So this is the mortality, prostate cancer over the number of years since 1983 to 2012. If you look at this, lung cancer mortality has gradually come down over the past 20 years. Colorectal cancer, almost the same, if not. Prostate cancer mortality did go up here, but then gradually it's declining, gradually. So still the number 3 cause of death in men with solid cancer. So, rate of prostate cancer diagnosis, incidence, and mortality. So you see here, big spike here. And the reason of this spike was? Anybody?
PSA.
PSA. So late 1980s, PSA became available early in 1990s for commercial use. And that's where the big spike of the prostate cancer diagnosis was. And gradually, that has declined. Mortality, declined, but not as much as the incidence of the prostate cancer. So here, we were diagnosed as too many cancers who didn't need to be treated, and people were not going to die due to those cancers. And that's what we've noticed over the number of years. And this is another way to show you in the bar graph the risk of low to advanced prostate cancer. Before 1990s, the risk of low-grade prostate cancer was on the lower side. All of a sudden, it gradually went up, right up here in 2000. It has stayed the same. The risk of advanced prostate cancer, this was all diagnosed with digital rectal examination or patient symptoms before 1990s, before PSA. This has really declined over the years. The intermediate risk has almost stayed the same, and the high-risk prostate cancer has also stayed the past 10, 15 years, but it reduced prevalence of high-risk prostate cancer. So as I said, I will be talking a lot about level 1, level 2, level 3 evidence of prostate cancer assessment with DRE and the PSA test. So digital rectal examination, so level 2 evidence. So it is recommended that men who comes to you, you should be doing a digital rectal examination. What we're looking for any induration, any nodularity. Asymmetry itself does not mean prostate cancer. You can have one lobe bigger than the other lobe. It does not mean it is prostate cancer. So the positive predictive value of DRE will rise as the PSA rises. So if the PSA is increasing, there's a concern that your man could have a prostate cancer. So there's a high chance you will have a normal DRE. What happens if you just diagnose prostate cancer by digital rectal examination? The chances are these cancers are advanced cancers as compared to when we diagnose prostate cancer with PSA. So with digital rectal examination, the chances of getting advanced cancer is higher with age and grade. What is PSA? It's a glycoprotein. It's produced by the prostate acini, prostate glands and ducts. And PSA through the prostate gets facilitated into the circulation, and that's how we detect it. PSA itself does not rise just due to prostate cancer. There are a lot of other conditions PSA will increase. Prostate hypertrophy, urinary tract infection, prostatitis. So these ejaculation and digital rectal examination, these are not definitive cause of increased PSA, but it's possibility that after ejaculation or after digital rectal examination, PSA will temporarily increase in numbers and level. So how can we tell that we can increase the sensitivity and specificity of the PSA? Is it just one PSA level which is going to indicate your patient has a cancer? Is it PSA age-specific PSA? Is it race-specific PSA? PSA velocity mean increase of PSA with time. PSA density mean PSA related to the volume of the prostate, or the ratio of the PSA. These are different ways to increase your sensitivity and specificity of diagnosis of prostate cancer with PSA. PSA does vary. It's not the same when you send your PSA to one lab as compared to the other lab. So when you are getting your PSA, it's best to compare the PSA from the same lab. The variation can be almost up to 25%. So that will reduce the variability if you're getting your PSA done in the same lab. I believe in Canada, all the labs probably, I'm not sure they use the same assay or not, because Abbott has an assay and other companies have an assay. I'm not sure, but actually, you know anything? I don't know. But when I do PSA, I always tell my patient, go back to the same lab when you do your PSA again. So what is PSA velocity? So you do one baseline PSA, it is high, but you do not put all your eggs in one basket saying that, okay, your PSA is high, you have a chance of having a prostate cancer. So 3 PSA determination over 18 months. You said it, 1 month, 6 months, 12 months, whatever it is, 3 PSA determination. If the PSA rises, if the PSA baseline is between 4 to 10, increase of 0.75 mil per year is considered significant. But if your PSA is less than 4 baseline PSA, your threshold is lower. Your threshold is 0.4. So depending upon the baseline PSA, the increase of PSA over 3 different PSA numbers will put you at a higher risk if the PSA increases more than 0.75 or more than 0.4. Same thing applies to PSA velocity according to the age. Younger the age, lower the threshold of increase of PSA as compared to older the age. So if you're younger in age, you're going to consider 0.2 nanogram per mil per year as compared to 0.75 nanogram per mil per year as increase of PSA over time period. Age-adjusted PSA, this was determined from different clinical trials, the prostate cancer prevention trials, that the younger the age, your threshold of the PSA is lower as compared to older the age. So if you're 80-year-old, your higher threshold is 6.5, but if you're younger, your threshold is 2.5. The PCPT and also the, what was the Avodart prostate cancer trial, they determined that there's almost 25% increased risk if men have PSA of 2.5 and less. 25% increased risk of having a prostate cancer in those clinical trials. PSA density, this is another way of increasing the sensitivity of the PSA by have the PSA number correlate to the volume of the prostate. Prostate has a peripheral zone and a transitional zone. Transitional zone contributes to the benign prostate hypertrophy. That mainly contributes to benign prostate hypertrophy. And the peripheral zone is what you're more looking at as prostate malignancy. That's where the prostate malignancy occurs. Prostate-specific antigen density correlates the size of the prostate to the PSA number. So PSA density of more than 0.15 puts you at a higher risk. And the prostate volume has to be measured by transrectal ultrasound. You cannot have a suprapubic ultrasound to measure the prostate volume because you cannot have length, width, and height calculated from a suprapubic ultrasound, clearly. Unfortunately, ultrasound and PSA density, there are controversial reports about PSA density that it does not really improves in prostate cancer screening. It adds additional cost, it adds additional controversies because prostate volume calculation could vary from technician to technician. So there is extra cost to do an ultrasound, and it might not increase the sensitivity of the diagnosis of prostate cancer. So the final thing comes is total to free PSA. We all know that, we all see that it's in the requisition. You have to take an extra box when you order a total free PSA. Why do you order it? When do you order it? That controversy still exists. We used to say that it should be done when the PSA, baseline PSA is between 4 to 10, but we have reduced the threshold to 2.5 now. If PSA is between 2.5 to 10, then you can consider total to free ratio as it is more sensitive to increase the sensitivity of the PSA. PSA is bound to anti-chymotrypsin and globulin in the bloodstream. In prostate cancer, the PSA actually directly gets secreted into the bloodstream. The ratio between the total and the free will be lower if there's a risk of having a prostate cancer. So if the ratio is less than 10%, which is 0.10, there's a higher chance of having a prostate cancer. If the ratio is more than 20%, 0.20, there's a less chance of having a prostate cancer. So every patient who comes to you does not need a total to free ratio. If you've done a PSA velocity and you're still concerned, or the baseline PSA is between 2.5 to 10, depending upon the age of the patient, you can consider total to free ratio to stratify the risk factors for prostate cancer. Total to free ratio is not useful after a patient has had treatment for prostate cancer, whether that is surgery or radiation or hormone therapy. You really want to know the absolute PSA value in those cases. We do not check for total to free PSA ratio because it's only helpful in improving the sensitivity of the PSA test as such. So what do? The prostate cancer is scored, given a Gleason score from 1 to 5, and then we add different Gleason varieties presented on one slide and adds up the score to the Gleason sum. So what you see is on a Gleason, when we tell you, okay, patient has a Gleason score of 6 or 7, it indicates patient either falls into the 6 means 3 plus 3, you don't see 2 plus 4. If you have 7, 7 could mean 3 plus 4 or 4 plus 3. So when we see prostate cancer in this range, 3 plus 3, these are called low risk prostate cancer. When you see prostate cancer in this range, 3 plus 4 or 4 plus 3, as soon as you start seeing 4 and 5, these are high risk prostate cancer. If maturity is 4 or 5, those are high risk prostate cancer as compared to 3 plus 4 or 4 plus 3. So you've done a PSA velocity, and you've examined the patient. the question arises now, patient is going to be referred to prostate ultrasound and prostate biopsy. There is increased risk associated with prostate biopsy, and this has been clearly SEER database and also the Ontario data, which was published just recently last year. There's almost 2% increased risk of complication related to prostate biopsy, and there have also been deaths reported related to prostate biopsy, and that includes hospitalization, septicemia, and even bleeding and transfusion. So the prostate cancer screening controversy has been there for a number of years. So U.S. task force came in 2011 and recommended against prostate cancer screening. If you look at it, it says grade D recommendation. So U.S. task force recommends men should not be screened for prostate cancer. It also says it's a grade D recommendation. Grade D recommendation means it's not recommended. So we recommend do not screen prostate cancer. It's not recommended screen those prostate cancer. So you're contradicting your own statement. We recommend that you do not screen prostate cancer, but it's a grade D recommendation, mean it's not recommended.
So double negative.
Double negative. So that's what it is. Here, I know as an American colleague, I will get your input. And on U.S. task force recommendation, so the American Urological Association, the recommendation everyone follows, says that it should be a shared decision amongst the clinician and the patient to recommend prostate cancer screening with PSA. Age you should begin screening is 40. Patients who are black or high risk with a family history of prostate cancer should begin screening at age 40. But U.S. Preventive Task Force says no, 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 no to everything. American Cancer Society indicates that 40 to 45 age to start screening for men as compared to the American Urological Association. But U.S. Preventive Task Force says that no, you don't need to do this. So this was published back in 2012, May, in New England Journal of Medicine. And I just recently heard that the screening number has drastically gone down in the U.S. with PSA over the past 2 years, a year and a half or so, that men are not being screened. So that's what we have been doing in Canada over the past number of years, that we do not screen each and every man who comes to our office. We do not do PS on each and every man who comes to our office. And so the criticism against the U.S. task force recommendation was that they really do not clearly look at all the results of the clinical trials. They based the results on 2 clinical trials, which was the prostate, lung cancer, ovarian cancer trial, which is a large U.S.-based trial, and the second one was the European trial. The European trial itself did not have a long follow-up on these patients, and they did not place any weight on other clinical trials done in other countries of the world. And there was some contamination of PSA because these are the men who had PSA, no PSA. They followed them, and the PLCO trial had contamination because some of these men who were including in the no PSA arm actually had their PSA done prior to including in the trial. And they did not also concentrate on their treatment and follow-up, and they mostly focused on their mortality data. And they did not also look at the active surveillance patient, which we have been following for the past number of years. So there were a lot of criticism to the U.S. task force recommendation of no prostate cancer screening. So the PSA screening itself has doubled the risk of receiving a diagnosis of prostate cancer over the past almost 20 years. A lot of the cancers we diagnose with PSA itself do not need any treatment. They will not lead to any long-term risk to a man's life. And we know that from different clinical studies, European and US studies, that there is a modest decrease in the prostate cancer mortality, whereas the US study did not show decrease in prostate cancer mortality with PSA screening. Treatment of prostate cancer as such, when you find them with PSA screening in an earlier stage, leads to a lot of morbidity and even mortality. And in men, in the manhood, in sexual dysfunction, urinary control problem, with radiation could be bowel dysfunction, and secondary diagnosis of cancers. There is about There was a recent paper published from Ontario Cancer Registry, patients who've had radiation for prostate cancer. They just looked at their complications, admission rates, and secondary malignancy. There's about 4% risk of diagnosis of secondary malignancy due to radiation, 10 years follow-up of these patients, 10 and more. So men who want to consider prostate cancer screening, they need to be counseled and guided properly before going through any screening, and also need to be discussed about the harm of further investigation and also treatment. What do we know from Canadian prostate cancer screening guidelines? So this is what is recommended. Life expectancy. If your chance you're going to live another 10 years, what you are today, and you are healthy man above age 40, or if you're 40, black, with the family history, or with the family history of prostate cancer, you can consider baseline PSA, and then further screening with PSA. Annual screening is recommended, but you can even screen them every 2 to 4 years. Initial screening should include PSA and a digital rectal examination. Other tests which can improve the PSA sensitivity, specificity could be PSA velocity, PSA density, or the total to free ratio. If PSA is above 4 or PSA continues to increase, there might be increased risk of prostate cancer. That's where you might consider these patients to go through prostate biopsy for further diagnosis and treatment. So going back to this gentleman, I don't know how to go back to that slide from here. So 44-year-old gentleman who's healthy, who has minimally bothersome lower urinary tract symptoms, and who has no family history of prostate cancer, who's a Caucasian. So what do we do now? I know if he's in the US, he will not be screened, he will not be examined. The question arises, what do we do now in Canada? Anybody? We'll talk about that later when we get on the podium, all of us. So our recommendation is you should sit down and talk to the patient. If he has no family history, you can do a baseline rectal examination. Our recommendation is he does not need a PSA at age 40. Yes, at age 50, you can discuss the pros and cons of PSA to this healthy gentleman, and then after your discussion, you can offer a PSA. If his PSA is less than 1 baseline PSA, it's recommended that you don't need to even repeat the PSA for the next 4 to 7 years. If his PSA baseline is less than 1, if he has no family history of prostate cancer. So I don't know if I have enough time to go through the treatment of prostate cancer, or we should just, I should just stop here. What is active surveillance? Once your prostate cancer is diagnosed, once your patient is diagnosed with a prostate cancer, then you have to go through the treatment algorithm for the management of the prostate cancer. Active surveillance means you are following this patient. What you are doing is delaying the treatment to the time when the patient is actually going to need a treatment for prostate cancer. And it is very possible that some of these men will never need to be treated for prostate cancer. The treatment is recommended when you think you can cure the prostate cancer, or if there's a disease progression, either due to PSA increase, either clinically you can feel there's abnormality, or repeat biopsy shows progression of the disease on Gleason's grade, and also the volume of the prostate cancer on prostate biopsy specimen. It's not a watchful waiting. Watchful waiting is you're not treating your patient until the patient develops symptoms. So here you're delaying the treatment until the time comes you can attempt to cure the prostate cancer. Other treatment options available are brachytherapy, external beam radiation therapy. Because of the time constraints, I won't go into the details of these treatment goals. The idea for non-surgical treatment is if the patient is not a surgical candidate, if the patient's life expectancy is less than 10 years, or if there are other competing deaths, competing causes for mortality or morbidity in a patient, you do not want to offer surgery, you want to consider non-surgical treatment. So either brachytherapy, external beam radiation therapy. Radical prostatectomy is still considered the standard of care for prostate cancer. It can be done open, laparoscopic, or robotic. The idea is to remove the whole prostate gland along with the seminal vesicles, and or remove the pelvic lymph nodes depending upon the indication. At our place, we do offer our patients open, and Dr. Chawla is the only one who does laparoscopic prostatectomy. Hopefully, we will be embarking on getting into the robotic program in the future. Times will tell. The risk of complication is a blood transfusion, urinary incontinence, erectile dysfunction. Laparoscopic prostatectomy does reduce your risk of blood transfusion, hospital stay, but the overall outcome over the years in different clinical trials, which is the erectile dysfunction or incontinence, is the same whether open or laparoscopic or robotic surgery. So I was talking to somebody about the management of any condition. They said, don't choose the surgery, but choose your surgeon. So people come there, oh, I want a robotic prostatectomy. It doesn't mean you're going to have the best surgery with robotic prostatectomy. You choose your surgeon. If Dr. Chawla is the expert in laparoscopic, I would go to him. If Dr. Jain is an expert in open prostatectomy, I'll go to Dr. Jain. So choose your surgeon, not the surgery. Okay, key message. Prostate cancer screening decreases deaths from prostate cancer, but there is significant risk of over-detection and over-treatment, and that's the reason U.S. Task Force came in with their guidelines recommending we should not screen and over-treat a patient. Active surveillance is a very good option for selected patient population, and surgeries and radiation remain the standard of care, and we would like to offer this treatment to men where we can help them and prevent long-term risk complication. They do have their own risks and benefits. Thank you.